So shall we start?
Sir, we are in live. Good to go.
Okay. So good evening, everybody, and welcome to the second webinar of the ACNS YNS monthly webinar series. So just to introduce, the Young Neurosurgeon Society of ACNS was formed recently under the aegis of ACNS with the kind blessing of Professor Yoko Kato and our advisor and mentor, Professor Azmi Alias. We've already had one introductory session last year, and this session, this month onward, we are having our monthly webinar series, and we were doing it in a little in a different way. The society thought that there is a lack of bridge the young neurosurgeons and the experts of the neurosurgery, and this bridge should be connected. So this is a hybrid way of webinar series we thought of, and we're coming up from this month onward. Every month we'll have where there'll be one expert speaker of neurosurgeons from all across the globe per webinar, and along with that there'll be one YNS speaker. So two of them will be speaking mostly on the same topic and from the different angle. One is the view from the expert faculty, another view from the YNS faculty. So I think that is a perfect way to bridge the gap between the expert and the beginners. And so this month, today we have our mentor and advisor, Professor Azmi Alias, as our guest speaker, and Professor Soichi Oya as our YNS speaker. So there you can decide how you want to take it, in a debate way or in a straight ahead. So let me introduce both the speakers. First of all, we have Professor Azmi Alias, who is the head and senior consultant neurosurgeon at Department of Neurosurgery, Tunku Abdul Rahman Neuroscience Institute Hospital, Kuala Lumpur from Malaysia. And he is also executive board member of the ACNS, and he's also a member of Asian Australasian Society of Neurosurgical Society. Apart from that, he's a coordinator and executive editor of Asian Journal of Neurosurgery. And the last, he is a very well educator and helper for the young neurosurgeon. And he's very active on the Facebook. You must have seen through these posts. Second, we have YNS speaker, Professor Soichi Oya, who is the professor Department of Neurosurgery at Saitama Medical Center, University, Japan, with the keen interest on skull-based surgery and vascular surgery. So can we open today's webinar? Professor Kato, with your permission, can we open the webinar and start the webinar? You need to unmute.
Yes. It's wonderful guest today. So as a second our webinar for YNS, I think we expecting the lectures. Thank you very much for the introduction.
Yes. So with me today we have Professor Itichai as a moderator. Dr. Liu and Dr. Sneha will be the co-host for the session today. So we can start the webinar. Professor Azmi, can you share your screen, please?
Let me share my screen. Okay. Okay, can you see my screen?
Yes, sir. It's visible and you're clearly audible.
Yes.
Okay. All right. Thank you very much. First of all, I would like to thanks Professor Yoko Kato for their support forever to young neurosurgeon development, and congratulations to the newly appointed YNS of ACNS, which is chaired by Dr. Liu and also Sachin and the team. So I would like to share my experience on this specific topic, which is endoscopic endonasal skull-based surgery, lesson learned. But my presentation today a little bit different from what I used to do, because I would like to share my experience. How do I develop endonasal skull-based as a beginners, as I go through how I underwent my training until how I establish the works in my center in Kuala Lumpur. So a little bit about the meeting today. So thank you very much for the invitation. So briefly, the outline of my presentation will cover the aspect of training, which is very important, especially young neurosurgeon who wanted to start their career, because young neurosurgeon means 45 years and below. So you should start somewhere, and by the age of 45 or 50, you already establish some niche area or area of interest. So I will cover also about how I choose my partner to form a team, and case selection. I will share a little bit about some complication where it really teach me and my team, so that we really already change our approach and our attitudes in managing this approach, and about future development in our hospital. So a little bit about hospital. This is located in the Kuala Lumpur. So it's about, it is 2,500 beds. We have adult and children hospital. So we have a multidisciplinary team support. So this is the dilemma that we face now, the endonasal skull base performing under PPE. This picture was taken 2 weeks ago when we have a sudden rise of COVID for the fourth wave in our country. And when the patient have rapid visual deterioration, functioning acromegaly, but the COVID status was not sure, she came from a red zone, and this is how we have to done ourselves. And this is not easy, what they call it, a situation where you have to do it everything in a very close method, and you cannot break the protocol because it will end up in safety. So, but this is could be the future and now, as we face COVID when you do endonasal surgery. Okay, as we know that there are a lot of development, and endoscopic surgery actually started with a pituitary surgery, which was very popularized in 1990s. And we know that with this technique, we can approach the entire anterior midline skull base, right from the frontal sinus down to C1, C2, and the various approach have been divided. Either you use transsphenoidal, transtuberculum, transplanum, as well as transclivus. And this is a cadaveric pictures that we took about in 2007. So it shows that the importance of laboratory training. So when we are a neurosurgeon, we are very familiar with the brain. But when we approach the endonasal, we have to go through the nose. So we must master the anatomy of the nasal cavity, even though it is done by your partner, especially you work with rhinologists, because when the complication happen and the perioperative management, it also involves the nasal cavity. So make sure that you have a good training, not only drilling with the intracranial, but also you need to understand the anatomy of the nasal cavity. So there are various techniques and a new technology, like now we have a 4D, 4K, HD, and the image, the visualization, the endoscopic resolution are very much improved. That allows us to recognize more detailed picture of the anatomy. When you have a detailed picture of anatomy, means you have to preserve more. So rather than you have to remove more. So this is a good example when we first started as a case of functioning microadenoma. This is actually acromegaly. You can see a tumor here. So using a navigation, especially a beginners, is quite important. But if you don't have, doesn't matter. You go by anatomy. So we have at that time we have our navigation system installed for the cranial. So we use as a beginner so that this can confirm the position. So when you do endoscopic endonasal, especially in pituitary, it is completely different compared to expanded approach. So endonasal pituitary surgery, the only problem with pituitary. So you got to preserve the turbinate and everything. If possible, you limit your opening to the target area, and you preserve the endonasal anatomy and so on. If you can see here, we just push the turbinate laterally, and then we go to our target. The opening, we do not expose the entire sella. We do it slightly different from usual method where people like to skeletonize everything, but selective adenomectomy, you can just need to open the target area. So we use the navigation actually to find the margin between the normal gland and the tumor, and we make a opening on the dura, and then you can see here the tumor actually whitish. It is soft, easy to curate. You can suck it, but at the same time, you must make sure that you should preserve the gland. You have to eliminate whichever tumor that you can find. At the same time, if possible, avoid CSF slit. You can see a very thin arachnoid layer that showing that your is intact. if you can manage to do it without CSF leak, then at least you save one problem, because CSF leak is associated with many problems. You can see a acromegaly, small tumor, but make a patient giant. So we can do other method, including tuberculous cellular meningioma. You can see this is one of our cases that you can even see the anterior skull base, anterior cerebral artery, ACOM. You see, this is one of the pituitary tumor. You can simply goes into the third ventricle from the endonasal approach. Okay, this is another extreme of cases. You can see if we start from the small, and as we have experience, we need a bigger team. So this is a more complicated case. As you can see, this is actually a chordoma involving the clivus, but unfortunately the tumor is so big. So involve the lateral, it caused subluxation of C1, C2, the tumor has invaded into the skull base, it's caused brain-stem compression. You can see a spinal cord already signal change is that because the tumor compressed, it caused instability. So this is, we thought initially, could be adequate if you approach with endonasal, but after detailed investigation, you need to evaluate. We need multiple team. It is not possible just to do endonasal approach. You have to make a combination approach where we have a full of a team of people from multiple discipline of surgical discipline involving the ENT surgeon, rhinologist, maxillofacial. We need a good radiology to support us. We even include our radiation oncologist when we deal with the endonasal tumor. So new technology, you can do 3D printing. This is to simulate, to see whether what type of instrument that we need. We need fixation from the cervical. So we decided to do this case after having a multidisciplinary team meeting. We do it in a phase, but in stage. If the patient is stable, we will complete it. But if it is patient not stable, we do it in stage. So we simulate. It is quite important to have a good anesthesiology. We simulate it. Phase 1, we do awake fiber optic intubation. We monitored MEP and so on. We do tracheostomy first because we know the tumor is so huge. Definitely patient we need upper airways to be protected. And then followed by phase 2, which is one by one, if by maxillary swing opened by the maxillofacial team, and followed by ENT surgeon, and followed by neurosurgeon. And this is a summary of the maxillary swing. So you can see that you need a multidisciplinary approach. Even the scope is only instrument, but when you approach skull-based tumor, you need to be versatile. You need to use sometimes combination of microscope, endoscope, not only neurosurgeon, not only radiologist. You may need other multiple team, which include radiation oncologists and so on. So this is just to show a summary of the lesion of the approach, and then we put the patient on a collar. Then we turn 360, and we use a navigation actually just to guide, because we occasionally do OC fusion, but it's okay because with navigation, with precision, will help you to do a fixation. So this is an immediate post-op. You can see the patient can move the face, and pain actually much improved. But when you talk about endonasal approach, there are many complications. This is a very important. This is not a checklist that you should have. This is a checklist that you should not have. If you have one, that should be enough. You must learn from each complication and how you address it. Okay. So I would share that the person that actually inspired me to learn about endoscopy was our late Professor Arsepeneski. He came to Asia Pacific, visited our hospital in 2003, and the year after that I joined him was as a fellow for 1 year. And another guy that really contributed to my development was Professor Robert Reich. He was a co-worker of Arsepeneski in Germany. So there are basic things that we learn, fundamental. Not only go in and do surgery, but you need to have a very good pre-operative plan. You need probably get advice from your masters or even your same colleague who has experience. It doesn't matter. Either junior than you, but as long as they have experience, you can get opinion. So the other thing that important that I really pick up was the laboratory training. So in Germany at that particular time, Arsepeneski ran 4 courses a year. So every time we run a course, we have to prepare the cadaver. So that is where we learn. Preparing the cadaver for a course is another training. So you clear the nose, that's where we learn the anatomy of the nasal cavity. Of course, the anatomy of the cranial, we are quite masters, but To see the anatomy of the cranium from the nasal cavity is need a different kind of approach and training, of course, combined with technology. So when I start, I don't start rapidly. So you can see I came back in 2005. We have to get a team first. There we need an equipment. At that time when I came back, I got nothing. So I have to start with a very basic thing, and we start slowly. Case selection, make sure the first case you do, success. So no complication if possible. If you have one mortality, you need another 99 cases without mortality so that you have only 1% of death. So this is very important. Try to minimize your mortality and morbidity, but case selection is very important. That took about 2 years before we jumps up, because when we have more experience, we go to more difficult case, we got more team, we train not only surgeon, but also our staff, our scrub nurse, and the support team. This is very important. Now we will do about 50 to 60 endonasal approach regularly in our hospital since that time. So again, laboratory, we bring in our colleague from Germany, we start our workshop in 2007, okay? So this is 2008, and within 3 years, I was appointed, I think, to join the Neuroendoscopy Committee of the World Federation. I must thank Professor Yoko Kato. She's the person responsible for that. So then we expand. We learn from the expert like this. You can see Daniel Pravadello, Professor Joe Pujari was there, and then we have Professor Andre Gotonui that helped us to build the team. Not only one surgeon, but also the team need to be prepared. So we even do our surgery, live surgery in the hospital so that the hospital administrator know what we need. The expert give the advice. Look, your team needs such thing. So this is very important. When the expert come, they give some impact. They will give you not only moral support, but strategy and even politics. You know, the administrator will realize that, oh, this is something that we need to develop. This is among the, among the secret that how we can manage to get the support from the entire team and the administrator. So at that time, Andre Gotonui came, Patra and Roman Crow. So now choosing a partner. So when we start, you must remember that endoscope is just an instrument. Nasal cavity is just an anatomy, but you need a good partner. So before I was in Germany, I already contacted my colleague. She was actually a lady who was trained by Professor Heinz Steinberger in Vienna, and then also trained by Professor Wolfgang Graf. These are a big name, okay? So they learn from basic, they teach their student, and we came back in 2005 when we merged. So unfortunately, rhinologists are quite easy to move because they are very valuable in private sector. So they move. So I've been working with 5 rhinologists, but this is the first establishment phase was very important in my entire career. Now, when you start the endonasal, usually you start at the sella. And at the sella, there is one master gland, which is pituitary. If you look at this anatomy, this is actually by anatomy, the easiest tumor or lesion can be removed. This is just like a cherry. You can pluck it and problem solve. Okay, it's a very small and you can remove it. But you must remember, this tiny gland is the master gland. It consists 9 hormones. It is not only a growth hormone, it is not only prolactin. It's quite important for you to understand the anatomy, the function and this thing. So if you do surgery in pituitary region, you must make sure that this hormone, if possible, to be function or to be normalized after your surgery. For example, like this tumor macroadenoma, after surgery, it should decompress the optic nerve and it should preserve the hormone. This is very important for you to have not only radiological improvement, but also clinical function. You can see this is a Cushing. You can treat hypertension, diabetic by doing pituitary surgery. You remove the tumor, you eliminate the compression to the optic nerve, vision improve, hypertension and diabetic cure. So you can treat without medication if you do it, if you do your surgery very well. This is a Cushing macroadenoma. You need a very good team. So this is a radiologist, this is a ENT surgeon, this is endocrinologist. The axis of skull base is pituitary. You need a team. So this is how we get many cases, because we have a very good support from the endocrinologist, not only from my hospital, but neighboring hospital, but also the entire country of endocrinologists. They will refer you functional tumor. Non-functioning vision deterioration, you will get it, but in emergency or ophthalmology. But functioning adenoma, for example, like Cushing, TSH-OMA, acromegaly, all will be referred by endocrinologists. So some tumor or some scar-based tumor, you need what they call it radiation oncologist to cover. So this is a very important. Then you can collaborate more. Okay, we even have established dedicated nurses that to take care of that area. So this is example where we have a first experience at TSH-OMA. They was referred by endocrinologists, but we have an MDT. The radiologist say that there is solution there, and you look it carefully. Yes, there is a little bit of swelling on that. So this is a hyperthyroidism when the TSH is elevated and T4 also elevated. So we decided to go in, but of course with some experience, so you can remove the tumor. So this is how we treat thyrotoxicosis by doing a selective adenomectomy. You make an incision. You need a very meticulous dissection because the gland are very small. You need to preserve the gland. If you look at the MRI, it's a normal size gland, but only one part containing a tumor. You need to eliminate the entire tumor tissue. At the same time, you must preserve the normal gland. So at the end of the surgery, the TSH level should be normalized and the other hormones should be maintained. So you treat thyrotoxicosis by doing, what they call it, just selective adenomectomy. Endonasal approach have limitation. If you look at this line, this is where you can safely resect using an endoscopic approach from the endonasal approach. Whichever a lesion outside the line, there are limitations, especially if it's outside the optic nerve stroud and if it's outside the ICA. So you need some level of experience before you embark on that. But if you have a limitation, you better be safe. There are various techniques. You need to know which is selective adenomectomy for functional pituitary surgery, which require expanded approach. We need to remove some turbinate. You have a more corridor, for example, you do transtuberculum or transclavus, or sometimes you should just give up endonasal, you should go transcranial, and sometimes you have to do combined endonasal and transcranial. So this is one example where I think I thought I can do it better. So this is when we started, we also want to embark something outside the pituitary. So we go to, this is the tuberculum sella meningioma. You can see here, very nice. The gland is there. You can identify tuberculum sella meningioma. You should make a wider opening. So you, if possible, you should drill the optic strut so that you can eliminate the entire involved dura. But you can see here. So okay, so this is just to show you that the most important step, if you just starting to do endonasal approach, you must spend time looking at your ENT clinic, preparing the flap, because this is very important. You make a wrong, if you make a flap is too small, then you will not be able to cover your defect. If the defect, the flap is too big, sometimes it will be redundant. So you also need to know, make sure that your scope and your instrument are moving toward this area. So you need to know where they put the flap. So it's quite important, not just like a king, you ask them to prepare and then you come and take out the tumor and get away. So you must make sure that you understand the working need. And this is we put the flap there, a little bit of the technique. So you can see here, this is a mistake that I think I made because the opening was not large enough. Okay. But despite that, we managed to remove the tumor. But of course, we cannot get a Simpson one because there was a residual tumor. And you can see here, we split the pituitary gland and we remove the tumor. And there are some dissection and pulling, if you're not careful enough, if the hypophyseal vessel is stuck to the tumor, it can cause bleed. So it's very important to have a good wide opening so that you can get a tumor removal safely and you have a complete resection. And of course, at the end of the day, you need to preserve the critical structure, including, you can see here, all the hypophyseal vessels, the optic nerve being compressed, ACA and ACOM and so on. Okay, I'm gonna skip this. Okay, and during the preparation of the flap, so this is another thing that you need to focus. When you put the flap, this is again, I use only technique. Initially I use fascia lata, but nowadays I hardly use fascia lata. I put a gel foam instead of fascia lata because fascia lata also can cause morbidity in terms of infection. But if the defect is so big, you better use fascia lata. If you do pituitary tumor, you don't need this. So fascia lata, then we put fat peripherally, and we put our flap, and we use the tissue glue to hold the flap for a couple of days. So this is a craniopharyngioma. Sometimes you need to select the case properly. I almost thought this should be approached by endonasal approach, but luckily I found there is a black thing. In other words, there's a calcified craniopharyngioma at the area of approach. So I feel in my hand at that particular time, it is not safe to approach on endonasal in case of I stuck. So I decided to go transcranial, but I make a right decision. If you can see here, the craniopharyngioma was really calcified. I have to use a high-speed drill diamond. You can see it's really stuck, the optic chiasma complex. So if you mobilize that area, the entire complex are moving. So it is quite important that sometimes you have to be very careful looking at the images before you embark on surgery. So we managed to remove most of the calcified area, but of course some area are very small. And here you don't ask for trouble. Do not go from endonasal. Sometimes you can see one of the clue, the ICA, MCA, anterior circulation surrounded by the tumor. This is a meningioma. Okay, so you can see you need a micro dissection that it is, for me, it's quite impossible for you to do from the endonasal approach, because we have to preserve the perforators. Yeah, you have to find, because this patient have a normal pituitary function. So you got to dissect, you have to find where is the pituitary stalk. You can see actually the pituitary stalk also surrounded by the tumor. So by manual dissection is much better to do using microscope transcranial approach. So this case for me is contraindication for endonasal approach. You can see, you can do it, you can do a very good job. You can preserve the stalk, you can preserve the what they call it, hypophyseal vessel, despite the tumor surrounding the stalk. So you need time, and you need to spend time so that you can dissect it properly. This is post-op. Sometimes the tumor is so big, so you need to know the limitation. So you cannot just go in endonasal for such cases. You cannot use nasal mucosa flap, the tumor already destroyed it. So you need to find the ways where you can do the reconstruction at the same time. You need to do combined endonasal and transcranial approach. So you can see here, this is a tumor. So usually when I do this, I like to open the cranial first. I raise a very good and thick vascularized pericranial flap. Okay, and then as you can see from here, so then I remove the tumor from top. I make sure that the dura are well resected. I preserve all the internal carotid artery and so on, so that later when the ENT surgeon come from below, it is quite easy for them, because all the intracranial structures already protected, already preserved, and is already devascularized. So they can do quite easier and faster job compared to they come from below and they do not know what's going on above. So when such tumor, I usually do transcranial, and once I finish, I put a cotinoid on top, so they become a guide for the ENT rhinologists when they come from below. Then they know where to stop. So then after that we come from above, we reconstruct. It's a big tumor, big defect. No way that you can simply put a flap. So we need a coverograph. So that's why I prefer for transcranial. You can use a split coverograph technique. So you can see a tumor pre-op, post-op, and so on. So this is just to show you another cases. I'm going to skip this very fast. Okay, you can see pre-op, post-op, and of course you need a good backup by radiation oncologist. Now the most important thing that I want to share is a complication. I have a couple of complications that really teach me. This is a residual pituitary tumor operated by another center. Patients still have a visual symptom. We thought this is quite easy case. We decided to go in. The plan was to go from normal structure, avoiding the scar. So, but this was done by, I think they used a nasal speculum, microscopic, so that the opening was diverted to one side. So we use a navigation. So you can see they put a fat, so there was a fibrosis around that area. So then I drill. So when I start to drill, I thought it is like a normal structure, but we try to avoid from the scar. But unfortunately, you can see here actually using, you need a very fine dissector actually. So when we remove it, and suddenly you can see this is ICA injury. It's a blowout very rapidly. So do not panic. So we were cool at that time. So we put a 2 sucker. So we try everything. So actually we put flow seal out, we put gel foam, everything out until the blood pressure start to crash. So you got no option at that particular time. So you can see the endoscope, the limitation when it bleed, it will contaminate your lens. So then you can't see. So then as you go in again, it contaminates again your lens. So the assistant also must very they need to know when to move in and move out. So when you cannot see, you can't do much. So in this particular case, when the BP start to crash, this is in 60-year-old lady. So we got to decided to immediately stop the bleeding. So at that time, we have no time to prepare the muscle. So we decided to put actually a Foley's catheter, and then we tamponate it and we pack with a nasal pack. So we pinch the nose and then the bleeding stop. But unfortunately, it doesn't last. Within 1 minute, it starts to bleed from the mouth. The bleeding from the mouth, and we have to pack the mouth. Then we have to call a backup. So where's the IR? We have to call our interventional radiologist. And we are very lucky, even though at that time we don't have our own interventional radiologist who already resigned. So we have a nearby university's expert. So we invited them, and they are very happy to support us. And the endovascular stenting was performed to escort the bleeding. You need to know how to handle complication when you start to do a complicated case. So muscle is the best. You prepare the muscle either from fascia lata. Prof. Chalitio, I remember he will just prepare one, you mark the temporalis muscle. In case you need, you just open and take the muscle, you mince it and you pack it. Some people use clip, but you need a very good opening. It's not easy to put a clip applicator. So we developed some algorithm in controlling the hemorrhage, as you can see here. Venous hemorrhage usually quite easy, especially from the sinus. Elevation, irrigation, elevation, irrigation. Sometimes you put gel foam weight. If you have money, use flow seal. It will also control well. Okay, and then this is another complication. It's a big tumor. Family refused for VP shunt. They say proceed first. We thought okay, we can go in, but actually the tumor has invasion to the thalamus. So you can see also part of the what they call it basilar artery was partly attached to the tumor. So you can see here as we go in, we managed to clear up the tumor, but there is a little bit of contusion on the thalamus as we try to remove the lesion, but somehow we managed to control the hemorrhage by putting a Surgicel and so on. Okay, and then we use a regular technique to prepare, and then we reconstruct. Okay, so that was no problem. We thought we have removed the tumor very well, but there was a residual clot. Okay, and then GCS drop. We put an EVD. You can see external ventricular drain. The patient improved slightly, but then she started to develop high-grade fever and intubated. And you can see here, there is a sediment down there. This is pyogenic ventriculitis. So this is the first time I had pyogenic ventriculitis. I'm not so sure what happened. We do irrigation flushing like other cases, but in this case, probably the patient has diabetes mellitus that increase the risk of having infection. So you need to handle, if complication, you need to master another technique. In this particular case, you do endoscopic lavage. That's part of our area of interest. You can manage to clear it, but eventually patient survive and we shunt the patient. So another complication, you can see a big tumor. Okay, so you can see we can remove the tumor. A lot of the tumor has been removed. Okay, but unfortunately, post-op patient developed CSF leak. So we decided to put external ventricular drain and wait for 3 days. Then there was a persistent CSF leak, and then patient started to develop fever. So we go in 1 week later. So we cover with antibiotic. We thought external ventricular drain is enough, but you can see here, number one, the flap was short and the flap was retracted, and there was a leak from the fascia lata. I made mistake. I elevate the fascia lata. There was a hole in the fascia lata. I decided to stitch, and close enough, it's leaked from that area. So we have to do, we redo. But good thing about flap, you can recycle back. Okay, but unfortunately, he developed a lot of complication. You can name it: meningitis, hydrocephalus, ventriculitis. He developed DIVC, 3 months intubated and ventilated. So lesson learned: CSF leak, immediate post-op, go in, don't wait. External ventricular drain doesn't work if you do big surgery, big defect. Yeah, you need to go in again, reposition your flap, or the best, when you position your flap, do it properly. Make sure your defect is smaller than your fascia lata, and make sure that your flap is larger than your reconstruction. In other words, the whatever come before must be larger than the defect. So you got a very good coverage. Yeah, and then we start to publish, because you need to set a standard. Okay, we publish our result, the first 10 years experience. To summarize, we have 4% CSF leak, no mortality, no morbidity, except CSF leak and 2 infection. And for pituitary function, we managed to preserve and about 31 to 62% of the pituitary function, which was disturbed preoperatively, and improved. In other words, recovery of the hormone after you decompress the tumor. Okay, this is another interesting finding that we find that we set the standard and we start eco training. In other words, we start to train, we collaborate. There was Amin Kasam who joined us in 2010. This is for Professor Otel, Salman Sharif. I think most of you know this guy. So we eco train, we train our people, we train ENT together, we train people in the region, in Asia, in the world, and so on. This is Charlie Teo with our Scolab team. This is Professor Sugo. I think this was in Bangkok in 2016. We also train our patient to understand about their disease. We have to work as a team. Okay, this is the future. So this is something that I'm very excited about. So in 2021, we already established one of the, we built a new hospital. We have a 3 Tesla intraoperative MRI and angio suite theater, which is located in another city close by. I think this is almost about 80% construction complete. With these facilities, probably we can do more, because we have a good ENT and rhinology surgeon in this hospital too. So in summary, experience is important to determine the surgical success. You need to have a dedicated, it's not everybody do everything, so you cannot get a volume, and then whoever do must have method of auditing, and the result, if possible, need to be at least reach the international standard. And when you want to do eco training, make sure whoever want to take over must be able to reach the standard that we have set and make it better. You need a dedicated multiple disciplinary team approach. As you can see in the previous cases, you need to master the anatomy. Anatomy. We are doing a neuron surgery, not just a drilling a bone, not a skull-based surgery, not a skull surgery. Yeah, you need to preserve the important critical structure. You need to be selective in your cases. You need to master your instrument, and you need to master each instrument limitation and technique, so that you can go maximum. It is beyond the maximum, you go for alternative approach. You must be very sensitive to your mortality and morbidity, cross audit, and this is team effort, not only you, but also your subordinate and your support team, endocrinologists, radiation oncologists, neuroradiologists, and so on. Okay, that is my end of presentation. Thank you very much. I hope I don't overshoot.
Thank you very much, sir. That was a excellent talk. Shall we take, how do you propose, sir? Shall we take the questions now, or we shall go for the YNS speaker and take the questions at the end?
I think we take the question at the end. So
Okay.
that would be more interactive.
Interactive. Okay. So Professor Soichi Oya is going to talk on the skull-based drilling technique. Obviously, not every tumor or every surgery you can go through endoscopic. At times, you may have to go transcranial, but the challenge is the skull-based drilling. So he's going to talk how to master the skull-based drilling technique from basic to the advances. Over to you, Professor Soichi. You can share your screen.
All right, I'm going to share my screen. You see my screen?
Yes, it's visible and you're clearly audible.
Okay, let me share. Okay. Okay, looks good.
Yes, sir. You can start it.
Okay. Thank you for the Professor Yoko Kato and their Sachin and their other coordinators for giving me this wonderful chance to make my presentation. My presentation today is going to be for beginners or young neurosurgeons who really wants to master or start to learn the skull-based drilling technique. So today's contents, I'd like you to understand the structure of high-speed drill. And also I'd like you to understand the stepwise application of drilling from basic techniques to intermediate and advanced ones. And also I'm going to show a lot of surgical movies for you to understand the rationale of the drilling technique. So I'm going to start with the basic techniques. So as a first step of drilling, we need to understand the difference of the tip, the function of the tip. So if you think the tip of the drill, like the Earth, the equator is the place where is the most efficient area. So you have to move the tip as you do like a curling book, like this, light touch and soft touch. So the perfect practice is the craniectomy. So this is the 66-year-old gentleman with the hemifacial spasm on the left side. So you see this is the left side, retromastoid area. So I'm start drilling. As you see here, I'm moving the tip of the head like I were doing the coloring books, and I use the equator portion of the drill because it's most efficient, and also with very soft touch and the light touch, you can achieve the so-called eggshell technique like this. Now you can see the thin, the bone, membrane like this. And now I'm finishing my craniectomy like this. So if you keep practicing this type of a drilling, you will get used to the handling of the drill. And now it's also useful in expanding the craniotomy. So this patient had a tubercular meningioma with the unplugged development. And this is the anterior part of the craniotomy, and you can drill the creased gully and also the edge of the frontal bone so that you can have the wide space, and you can insert a surgical instrument from various directions. And at the last part of the surgery, you can insert the drill shaft like freely like this, and you can open the optic canal, and you can remove the tumor invading the optic canal on both sides. This is the right side. This is a very important portion. This is the left side because the MRI, we cannot rely too much on the findings of the MRI. We really need to see on our own eyes, So the patient had a good visual recovery, and I also I just left a small piece because it invaded the ACOM complex. And the next one is the how to use the north hemisphere of the drill. This portion is the most powerful, and you should move this part from deep area to the shallow area. So I'm going to show this technique via the sphenoid ridge drilling movies. And this patient had the left side, large MCA unruptured aneurysm measured as 20 millimeter. I like to good exposure of the aneurysm. So I like to have the more inferior visual axis than the routine craniotomy. So I decided to utilize the transzygomatic approach. This is the left side. Now I am cutting the zygomatic arch so that I can deflect the temporal muscle as low as possible. And I'd like to expose the temporal lobe as much as possible. See, this is where I'm using the north hemisphere of the drill. You can put your strength to the tip of the drill because you are moving the tip of the drill from deep area to the shallow area. And also this is the anterior cranial base flattening. This is very important technique. So if you are putting up the drill like this, you cannot injure anything, even if the tip of the head slips inadvertently, and you can get this done very quickly. Now I can have I can create a very wide, ample space, and then the discoloration because of the compression of the aneurysm. And now I'm opening the cerebral fissure, and sometimes in these large aneurysms, there may be a firm adhesion between the aneurysm wall and the surrounding vessels. And this is another technique, coagulation technique. Now I'm shrinking the aneurysm, and I can create a little bit more space for me to work around the aneurysm. This is very important because this will increase the visibility of the area behind the aneurysm. Now this is the left side, so I try to preserve all the perforators like this, and using the temporary clip and reduce the pressure, intra-aneurysmal pressure. I put the large clip, and I'm trying to create the neck of the aneurysm. So this is the angioplastic neck creation technique. And I placed the multiple clips slantly, and ICG video angiography showed the aneurysm is gone. And as an intermediate step, these are common skull-based approaches, but I'd like to emphasize that their basic skull-based techniques are shared in common, irrespective of skull-based approaches. So I think their anterior cranioidectomy is their first, their technique for beginners to learn. So let me show this case, 61-year-old gentleman, left side anterior crinoid meningioma. And now I'm using the same technique, and I'm drawing the suphenoid bone, and now I'm flattening the anterior cranial base. You see, I'm using the north pole of the drill. I'm opening the superorbital fissure, and I'm drawing the thickened the optic roof. And also, it is very important to prevent the bleeding from the bone. There are many feelers because this is the anterior crinoid meningioma, but you really have to control these bleedings. Now I can see the optic nerve clearly. And after this has been done, I finally open the dura. And by doing this, I can take care of the tumor around the optic nerve first. And, I can just remove the tumor and preserving the optic nerve with no additional compression. And removing the tumor like this. I'm skipping this part. But, the skull-based technique is very important to create the ample space in the skull-based area. I'm not retracting the brain too much. I left a small portion behind the ICA but the patient had a mild cognitive dysfunction. I was very careful, but the perforator infarction occurred. And lastly, we need to learn how to use the Antarctica, this portion. This portion is characterized as the least efficient area, but it's very fine. And also we can use this area for heat coagulation. So this is the left side, the right side, not anterior cranial. This is the ventral petrous meningioma. And we utilize the transcondylar approach. This is the right side transcondylar approach. And I'm drawing the bone near condylar fossa. This is the condylar emissary vein. You see, I'm trying to control the bleeding from the emissary vein using the tip, using the Antarctica of the drill head. And by using this technique, this is a hypoglossal canal. I drill the base of the condyle without having the hemorrhage, venous hemorrhage. And I also like to use these thick dissectors. And after this part is done, I approach the tumor. And as you see here, sometimes we encounter this red membranous-like sheet covering the dura. You have to take care of this membrane because the histology will show there is a tumor cells here. This was a very, very hemorrhagic tumor like this, and the feeders were coming from the petrous bone like this. And to obtain the hemostasis, I used the same technique. I used the Antarctica of the drill head like this, and creating the space, and also I could achieve the good hemostasis here. And now the tumor was completely detached from the attachment. By this step, and so I could dissect the tumor safely from the brainstem and also the other, the labyrinthine arteries and the facial nerve. And lastly, I confirm the hemostasis again and use the tip Antarctica of the head like this. You have to start drill on the spot. You have to finish the drill on the spot. So that you can avoid the inadvertent, the catching of the cottonide of the other materials inside the operative field. So the patient had a temporary dysphagia, but he recovered very well. And now advanced technique. This is a 1-year-old Moyamoya disease. We need to preserve this MMA because this is there was the collateral fall. So this is the left side approach. So I'm harvesting the STA. So it was very thin because she was just 1 year old. So this part was harvested for the EDES. And this periosteal was harvested for later use of the duroplasty. And ICG video angiography showed how the MMA courses like this. See here? So I just marked the location of the MMA, and I used the drilling to preserve the MMA. Because sometimes, as you know very well, the MMA entered the bone, and it might be injured while craniotomy. So I just confirm, the MMA is not in the bone flap. And then I use the drill like this, cutter, then I'm protecting the MCA. And then I could finish. I found a very small cortical MCA on the frontal lobe. and the bypass was finished. And all the arteries were, including the MMA, were preserved very well. The postoperative MR-DSA showed a good patency of the bypass. And also another advanced technique is the suprameatal tubercle drilling. This patient was very young, but he had a right side trigeminal neuralgia. The CP angle system was very narrow. And intraoperatively, the space between the bone and the brainstem is extremely narrow. So I had to, drill the suprameatal tubercle like this. But as you see here, I'm protecting the petrosal vein like this using the suction tube. This is very important technique. And after moving the SCA, and I needed to have a better look to the trigeminal nerve. But while I was drilling, I always check whether I might violate the mastoid cell like this. You see here. So you really need to aware of this the possibility of injuring or entering just the mastoid cell. And also this is another example of the protection technique. This patient also had a protruded suprameatal tubercle. And again, this is right side approach. This protruded tubercle, prevents you from have a direct looking on the trigeminal nerve. So first I create a space here. And then, while I was drilling, I needed to protect this petrosal vein and this labyrinthine artery. You see here. So I used the suction tube. I placed a suction tube in between the drill and these important structures. This is very important. And by this drilling, I could confirm the culprit. This is vein. So I insert the small ball of the Teflon, and the patient had a pain-free result. And lastly, I'm going to talk about I'm going to emphasize the importance, that we should be aware of the tip size. This young lady had an acoustic tumor on the left side. Unfortunately, she had a high jugular bulb here. Okay, this is the left side approach. This part is it's just usual, the lutein procedure. And I found the facial nerve and the trigeminal nerve here. So this is the facial nerve. This is the interface between the tumor and the facial nerve. And then I move to opening the meatus. I use the large tip drill here. You see here? So I like to avoid the inadvertent entering or injured the jugular bulb. Now, to hollow out the jugular bulb, I use the smaller drill, and I frequently use the bone wax to displace the bulb. It's very fragile, but bone wax works very well. And now I could get the good exposure of the distal portion of the tumor around the fundus. And all the tumor was carefully dissected. So even for high jugular bulb cases like this, if you draw carefully, you can have a good access to the tumor inside the internal acoustic meatus, internal auditory meatus. And this is the final step. The tumor was completely removed. The gross total resection was achieved. The patient had no facial weakness. So this is the summary of my talk. That we need to learn how to use the drill head differently to suit the situation. Equator, North Hemisphere, and Antarctica, these are three important parts. And you need to learn these techniques step by step. And I like to emphasize the importance to start the drill and stop the drill on the spot. And you need to learn how to prevent the heat damage with the copious irrigation is a key. And also the suction protection technique is fundamental for skull-based drilling. Thank you very much.
Thank you very much,
Okay.
Professor. So now we'll open up for the questions. Dr. Sneha, can you take over the question and answer session and coordinate? Yes.
Thank you, Sachin. Thank you,
Yes.
Professor Asmi and Professor Oya, for those beautiful lectures, one diametrically opposite to the other. We'll first take questions for Professor Asmi. Dr. Alberto has a question as to how effective is the cadaver lab simulator training, and would you recommend that versus the normal anatomical training? Can they ever replace the cadaver labs? So what would be your opinion on simulators, cadaver labs, and actual training?
Okay, thank you very much. This is a very relevant question. In fact, I want to ask this question to other people. First, 10 years ago, cadaver was very relevant because it's quite easy. But now the cost for cadaver is very expensive. And when you organize a course, people pay and they want a better quality of cadaver. They want frozen cadaver, they want soft cadaver, which is a very expensive. And if you run a course also, you cannot get many people. So now the era of moving from cadaver to simulator. There are many simulator available, which is designed, but the simulator for me, it can be a virtual or it can be a physical model. The virtual is give you some concept, ideas, but you don't have the tactile sensation. Okay, you may have a strategy to do this, to do that, but the drilling is you cannot replicate the real cadaver or actually the real patient. And similarly to simulator, the model. Sometimes the model designed according to a patient before. Again, the tactile sensation, you cannot get the what they call the feeling of turbinate, the feeling of dura equivalence to cadaver. But definitely they will give you a judgment in terms of each step. First step, second step, whether they pass it or not. So this is a very important as a first step. But I think cadaver is still the best. But you need to be to have something like sometime collaboration. Some center, especially university, they buy one body, but they share with a different discipline. So that they can still generate income by using a different part of the body in a different session. For example, our colleague in Indonesia, so even our colleague in Malaysia, they buy the head and they know neurosurgeon using certain part, and then ENT surgeon will do another part, the ophthalmology. So they take once they have one cadaver, so they will arrange the courses in such a way that one after another, at the end they can fully utilize the cadaver, that they can get back the what they call it, the investment, and in fact they can make profit. I still believe that the best still number one is on patient, second is cadaver, then goes to model, and the last one is virtual. This is based on priority, but it is not possible nowadays. So like in my center, usually what I do is eco training. We cannot get cadaver in public hospital. So what we do, we give some courses or before, something like that, and we bring them to theater, and then we ask them to scrub with us. And usually I will assess them, and then up to certain level, if they pass through certain thing, then we will allow them to do, stepwise fashion. So, but that kind of training will take a longer time. Yeah. So I hope that answered the question, because I also want to ask that question to Alberto if he got a good model or whatever that we can probably share for the young neurosurgeon.
So that takes me to another question which I would like to ask. What would be the minimum training period that you recommend, either in the lab, cadaver, or the model, before you actually get started on a patient?
Okay. Well, it
for a young neurosurgeon especially.
Well, it depends on your center. If you are working in a high volume center, duration is not a question. So for example, if you have a center who do a pituitary or skull-base surgery every week. So usually for complex cases, I put maybe 10 cases, they scrub together, observe. But the problem is sometimes you need to know the outcome of the patient. Sometimes you get a personal referral, complicated cases. Then such cases you cannot allow young neurosurgeon to do. And nowadays litigation, medico-legal is coming up, especially in our country. So you need to balance that too. So I would say it's a very subjective assessment. Some trainees can be faster than the others. You know, sometimes you know their skill, it's their attitude, their skill, their knowledge. Yeah, some just interested just to remove, and then you can judge it. So I cannot give an exact number how many, but it is based on experience. But of course, you at the end of the day, your result will be audited by your co-workers, like the endocrinologist who personally refer the case to you, or ENT and so on. So I hope that answer your question. Maybe opinion from others, welcome. Maybe Professor Oya or Professor Kato.
Yeah, I think my opinion is that and as we told that the surgery, the real actual surgery is the best, classroom, for beginners to learn. So I think that we need to utilize the step-by-step learning process. I think if you have plenty of cases like every week, the beginner can start like a drilling of the anterior wall of the supinal, the sinus, and then you can drill the cellar, and by stepping like this gradually, I think you can gradually expand your knowledge about the anatomy. Also, you have to refill your knowledge using the cadaver dissection course or something. But I think there's a step-by-step process. So at least you need to present, you need to be there in the operation room in every case. I think that's my advice.
Yeah, I completely agree with Professor Oya.
True, sir. The point is well taken. Dr. Liu, do you have any questions? We can have questions from our participants.
I have a question for Professor Oya. You show us a very good technique of how to use drill. My question to you on two things. When will you use a diamond burr, and when will you use a rose burr? And in terms of size selection, do you think a bigger size is much more easier to control than a smaller size? And secondly, the speed. What are the preferred speed you set at maximum speed, and you control with your foot pedal, or what's your preference? Thank you, Professor.
Okay. So your first question, my answer is that for intradural drilling, I prefer to use the diamond burr. But for speedy drilling, and if it's possible, I think I will choose the steel bar. That's simple, criteria. And your second question is, usually I set the rotation is like 72,000 per minute. Okay, but I also control how strongly I push the pedal, and it's like the car. If you are driving a car, you can control the rotation speed by stepping strength. So I think that's another part I didn't refer to, but thank you for pointing out the important tips to control the strength of the drill?
There's one more important technique when I first using drill is for my boss. He always asked me to use two-hand technique, which I would better control. When you become expert, you can control as if you're using a pen or pencil. Then only you start using one hand. What's your opinion?
Yeah.
Dr. Wei, I have a question for you. Thank you very much for the whole concept. It was pretty new, the northern and the southern hemispheres. I found it very interesting to put it across like that. My question is, would you advise routine drilling in traumatic acute SDH decompression? Because that's where the beginners get started, the temporal base decompression. So do you advise your residents to use the drill in the emergency decompressions, or it's just the rongeurs? And the second question is, in doing so, sometimes the middle meningeal artery gets retracted. So I recently had one such experience. The vessel just got retracted with diffuse bleeding. We spent a bit of time to control it. It was just during a traumatic decompression. So in such cases, what would you advise?
For emergency decompressive surgery, we need to be very quick for our patients. The patient's safety comes first. So, we should not use the, fine meticulous drilling when we create a craniotomy for those patients. We need to get it done very quickly. But at the last step, like, removing the bone of the temporal bone, like the base of the temporal bone or some other part to finish your craniotomy after, decreasing the intracranial pressure, you already finished the decreasing the pressure. I think that's a good chance for beginners or young neurosurgeons to get used to how to handle the drill. So we have to actively create the chance, a lot of chances for those neurosurgeons to experience. If you have number of cases, traumatic cases, I think you should make use of those chances. But after you completed your, the most important purpose, to decompress the brain or to remove the clot.
Sure.
And I couldn't get your second question right.
It was when the middle meningeal artery retracts into the foramen and you're unable to secure the bleeding. So what would you advise? Further bony or
I mean, first thing, you need to have the good exposure of the MMA and where it's coming out from the foramen spinosum. And usually the MMA is covering the thick dura, and you can create the scissors is very good. You can use the scissors to create a gutter on the both sides of the MMA, okay? And by creating the gutters in both sides of the MMA, you can pinch the MMA by the bipolar forceps. And then you can coagulate the MMA with wide range, and you can cut. I mean, you can cut the MMA with scissors. It's very quick. And also, you can get a good hemostasis. It's totally different from the drilling technique, but it's very useful. You should try. Okay?
Yeah, sure.
May I give a short comment?
Of course. I was about to get to you, Professor Alberto. Please.
Thank you very much for the organizers and to both Professors Azmi and Professor Oya. So I asked the question about simulators, virtual simulators, because actually I feel like it's becoming like a fashion, especially in Western countries. It's like simulators are the something magic that can help young generations to skip cadaver labs or extensive training in DOR and something very, easy to get. But I also have the feeling that it's not like that, because still we don't have so much effective virtual reality operation rooms. So I appreciate your answers. And I have a question for Professor Oya. I noticed, and you mentioned that you use some protection when you have to drill a bone which is very close to sensitive structures like nerves. Nowadays, it's possible to use also other tools based on like ultrasounds, and these tools are supposed to give less heat, right? So I would like an opinion by you about this kind of tools. Why you still use diamond drill in those situations? Why you didn't switch to these new tools? Is there any reason? Thank you.
Okay, I have my specific reasons to keep using the high-speed drill instead of the ultrasound, the cursor, bone cursor or something like that. Because like I introduced my usage in my presentation, I can use the drill in more versatile, ways. By using the tip of the head differently. And I can control the strength of the drill power to change how strongly I step the pedal. So I can use more, like in a various way. And I know, it may create the heat. I know it may get caught the materials inside the operative field, but still, I think because probably I was trained like that is one reason, but it's the ultrasound, the cursor. It's more like monotonous for me. It's very simple, safe, but I like to add some other values or some other, tastes to protect the nerve also, and also finish the part quickly.
Thank you.
Thank you very much.
I have a question to Oya.
Yeah.
So I saw your drill has some plastic kind of protector.
Oh, yes.
To the sucker. What kind of high-speed drill machine or the product is it?
Yeah, in my presentation, I showed two types of the drill. One is a classic conventional one. Yeah. The shaft of the drill was not covered by the protector, but the new one is produced by it's commercially available from a Midas Rex. It's called a curve bar. Only the tip of the head rotates, and the shaft it's completely covered. So it's very useful when you use the open craniotomy endoscopic approach. Yeah, I recommend it.
So from Midas Rex, huh?
Yeah, it's very safe.
And your sucker also, I found that you have some protected tip. So is that detachable or?
Yeah, but I use that. The tip of the sucker is not very small or fine, and so I only use that protected sucker for extradural drilling.
Oh, okay. All right.
Okay.
Thank you very
much. It's kind of a big, yeah.
Very good.
Thank you for asking. Thank you for asking.
I also like the technique of the way you describe it, the Equator, Antarctica.
Yeah, I use that explanation to teach my residents.
Very good, very good.
Yeah. Thank you.
I have one question for both Professor Ashley and Professor Oya. In this COVID time, what is your any specific drilling related precaution? The aerosol spread and all that stuff. So in addition to the PPE, do you also use some covered space for the drilling so that the aerosolization is prevented? Are there any specific protocols?
Okay, who answer first, me or Oya?
We both.
So it's up to you, sir.
Okay, let me share our experience in my hospital. So first, of course, all cases that undergoing for AGP, aerosol generated procedure, which is endoscopic high-speed drill, so we will need a PCR test. So if PCR negative, then only we proceed. If PCR positive, we never proceed. No point. Because like say pituitary, they don't die of pituitary adenoma. They may die because of COVID. So let the COVID settle first. After 2 weeks, if PCR negative, then only you go in. Now the question is, in case of emergency life-saving, yes, then you have to use a proper PPE. So for example, you can use a plastic sheet to protect it. But most important thing is we always want PCR. Or at least RTK in our country. But RTK, the sensitivity can be very questionable. So it divided into high risk or low risk. If high risk, don't proceed. Get PCR. You know, if low risk, you may proceed. But now a lot of asymptomatic cases. About 60 to 70% of cases in our country, at least, they are asymptomatic. So again, very risky. So no surgery for COVID is the best. For COVID patient. Life saving, only you proceed. Don't, it is not worse to because I show you the case. What happened was there was sudden surge and our area become red zone. So when we become red zone, so the level of alertness is increased. So we have to really screen the patient. So unfortunately, patient came late and the RTK result not is a moderate and they come from red zone. So anesthetist insists of having PCR, but it's very difficult to send them back. So we proceed with PPE, but it is not easy because we use KN95 or N95. Then if you have some leak, then you got evaporation on your spectacle and your shield.
Too much fogging.
Yeah, at the end I have to do like that, because only one area I can see. And luckily at the end of the surgery, the PCR came back negative. Everyone like, okay, thank God. No, we open back everything and back like usual. So do not operate for me. It's not life-saving, not worth to proceed. Use plastic protector, that is another way. But get PCR.
Okay, as you may know, the rate of infection in Japan is extremely low. So if the patients do not have fever before surgery, we just do the same thing, before the pre-COVID era. And but like Asmi pointed out, the problem is the emergency case. So we prepare one room to negative pressure for those patients. And probably I have never had a chance to to operate on such patients, but if I have to use the drill, probably I should avoid the drill. I like to minimize the chance to create aerosol, So I will make the surgery as simple as possible.
Thank you, Professor Asmi and Professor. I think safety is of prime concern.
Our safety and the healthcare workers. Because if spread, the whole theater shut down and you cannot function. So that is worse than, So we really have to stick to protocol and make sure your staff all get used to it. And the problem with this donning and doffing, usually when you done, it's quite easy. But the mistake usually during doffing, when you remove it, if you don't follow the protocol, you can simply contaminate yourself. So it is not an easy process. It's a very stuffy. Even in the air condition, you still can sweat.
Very true, sir. Very true. Dr. Alberto, would you like to have a say on this particular question as to how do you practice in your place?
Well,
COVID protocols. And...
Yeah, we have very similar protocols, actually. I agree. You know, for transsphenoidal surgery, it's very, very rare we have to perform something in emerging settings. So I agree with Dr. Azmi about the fact that we wait until PCR is negative. So yeah, of course, in cases that cannot wait and we have to do surgery, you know, we have to wear masks and double layers of scrub. So it's very, very difficult. We all know, we all experienced this uncomfortable setting, but luckily those are quite rare situations, at least for transsphenoidal surgery.
Thank you.
May I have questions?
Do we have, yeah, any more questions from the participants?
May I have a question, please?
Yes,
Yes,
please.
yes, please. Yes.
Yeah. I have two questions, please.
Please continue. Please proceed, Dong. Yes, please ask.
Please introduce yourself and ask.
Yeah. My first question to Professor Oya, is there any difference in the drilling technique between extra and intra craniotomy? And the second question to Professor Amis, do you use the Doppler or navigation to identify the ICA in transsphenoidal surgery? Thank you.
Okay, I'm answering your first question. I think the basic techniques are the same, but you know, in my opinion, the intradural anterior cranioidectomy, you really have to be careful about catching, you know, other structures, including materials you use. Okay, but that's why people prefer the extradural cranioidectomy for the safety. Okay, but the basic techniques are the same, in my opinion. Okay.
Thank you.
Okay, the second question, yes, definitely. We have a very long, like a sucker Doppler. So if we drill, so I prefer to have, but sometimes when you need the equipment, it doesn't work. So it's happened many times. So the Doppler doesn't work, then you have to go back to the anatomy. So important thing when you drill, you must look at the images. Yeah. So there are many instances where sometimes you're being fooled by the septum, the intra sphenoidal septum. It's not always straight. Sometimes they goes and they curve into the ICA. I've seen the cases in front of my eyes when during my training, the surgeon are drilling, they keep following the septum, but actually they didn't realize that it goes exactly on the ICA. And usually complication happen when you do not realize you are drilling on the ICA. But if you are in conscious state that you are drilling on ICA, then usually you take all the precautions. You use a suitable high-speed drill, you know, you use a diamond and you shape it. You have to make it like egg-shell. You make it thin, you don't drill until you see the ICA. So you make it very thin, and sometimes I use Doppler. In my situation, I'm not so aggressive at taking the ICA. There are cases where we have to we do it, but for pituitary surgery, I never ever expose ICA. I would rather, because with opening, whatever it is, you can use 30 degree, you can use angle equipment to see it, and you can still maneuver to remove it. Because you must understand, the ICA is designed to be buried in the bone. It is not designed to be open. So some people say we should see everything. Yeah, good. But then when complication happen, then the ICA distension pressure, it is exposed directly to the nasal cavity. If the flap fail, then you expose your ICA to nasal cavity infection, the wall may be weakened. And if you do a good flap also, when you redo surgery, the flap gonna stuck on the ICA. You believe me, you go in for second case or redo, the flap also stuck to the bone, to everything. If stuck to ICA, it's very hard for you to remove it. So there is, for me, no routine exposure ICA unless the tumor involve ICA or encasing ICA. As long as you can avoid, you avoid. Yes, I use navigation if I have, and I use Doppler if I want to attack the ICA. But you have to be prepared, like I mentioned to you. Sometimes the equipment always fail you when you need a critical area. So anatomy is the critical point that you must understand. I hope I answer your question.
Yeah, thank you. Thank you so much.
I have one small question, Professor Azmi.
Yeah.
In one of the case you showed where there was a intraoperative ICA injury, you tried to stop it with the flow seal, but it didn't stop. You're lucky that you had an intervention team who stunted the ICA. What if it is a situation of a young neurosurgeon and there is no availability of intervention specialist? If there is an ICA injury, what do you suggest, like a protocol in a stepwise? These are the steps you should follow to stop it.
Okay, first, again, pre-op planning. If you think that there is a high chance of ICA injury, so you can make an advanced preparation, like what Charlie Teo give an advice. He think that if he want to drill the ICA or chance of ICA injury is there, so he already marked the area of where we will salvage the temporalis muscle, which is immediately available at any time you want. So he just make incision, take the muscle patch. So you can do it in less than maybe 1 minute. It's too short. It's a very quick, so you can get it. Because sometimes we use a fascia lata, but for you to go down and your team are struggling up there, unless you got two team, another guy just take out the muscle from the thigh. So because majority muscle works well, but you have to mince it. You have to either you stamp it with a hammer or you use a tip of scalpel blade and then you lay it on it. But you must be very careful to control the suction. And the endoscopic person that hold the endoscope is very important because he has to adjust it so that it doesn't contaminate. The other option is you can ligate the ICA, the neck, and then you can ligate it. Some cases you prepare it, it's going to attack. They already prepare the control the ICA in case bleed. They can just what they call it using a vessel loop to control it temporarily or put a clamp. But some advanced center, for example, like the place that I go in Germany, or I think in Japan also, sometimes they use an endovascular. From below, they occlude it using a balloon technique if it is happen. But endovascular IR is not easily available in every center. So that's why if you work in a small center, you have to think carefully in case you run into trouble, what is your backup? So if it's not enough backup, either you send the patient to a larger center or you do it with more experienced people with a good backup. Muscle, number one. Number two is, I think, ligation, and sometimes you can use a gel foam and flow seal. Or I've seen people repair it. I've seen someone show it in either they clip or they stitch it, so they can do it. But in my hand, I think it doesn't work because we don't have suitable equipment. I think maybe Professor Oya can share experience. Probably in Japan, people stitch or do clipping on the ICA injury.
But stitching under endoscopic surgery is a totally different talk. It's very difficult. So I have one short question. Did you try the manual compression when you had a carotid bleeding, like asking the residents get into the under the the blanket and compress the carotid artery? Was it effective, or you didn't try?
Yes, this is again very practical, because in any surgery, if you caught into trouble, your finger is the salvage. So yes, we did. We compress, but it doesn't stop. We were so cold at that time, but until the BP start to crash, the blood pressure crash, the anesthetist already, hey, look, you have to do something. Then everybody start to sweat. So what we did at that time, we used a Foley's catheter. Yeah, we used a Foley's catheter, balloon it, but it still bleed, and we start to use a very long gauze, tack gauze, and we even have to pitch the nose. But again, it stopped above, but it bleed from the mouth. So we have to pack the mouth. So that is really in a desperate situation. I only have one such cases, and I hope that is the end. That happened in 2009.
Yeah.
You know, 2009. I think one is enough. That I like. I always share this, and then you know, this is a very important message that we have to avoid. And another thing that I learned, even though endovascular technique managed to occlude in this case, but if you look at long-term effect, we have in our series in our hospital that endovascular stenting and the occlusion rate thrombosis can range from 30, 40, 60%. And this particular case actually died 6 years later with multiple brainstem stroke. So even you have a solution to stop the bleeding, but it is have associated risk. So the best is to prevent. If you can prevent it, you solve the issue. Similarly to CSF leak. CSF leak, intraventricular hemorrhage is the two culprit that lead to a lot of disaster. So that's what I learned from endonasal skull base and ICA injury, the prevention. Yeah. So do not expose it unnecessarily. You have to use the corridor adequately. If you need to remove the turbinate, fine. But I think it is not exposed, because some people argue there is a dehiscent. Dehiscent means there is not much bone, and about, I think, only 5 or maximum 10% carotid dehiscent. Means when you open the skull base, you have to be very careful. And then there is no bone at all. It is direct ICA, which is covered by a thin membrane. But God has created that only less than 10% has dehiscent, but 90% in the bone. So follow the nature. You follow, you respect the nature, you respect the mucosa. I think the anatomy and nature will respect you too. So I completely disagree that, especially young neurosurgeon, we show everything expanded, remove it, remove that. Because when you have endoscope, you should be able to see more, means you should preserve more. So that is minimally invasive preservation. Destructive surgery removal is easiest thing to do. That to preserve and to reconstruct is another thing. You have to be really careful on that. I hope that answer your question.
Yes, thank you, sir. So do we have any more questions, or shall we conclude? So I think if there are no questions, we'll conclude. It was a wonderful evening, both Professor Azmi Alias and Professor Oya. The way you explain, especially Professor Azmi Alias, you are truly a mentor and advisor. The way you explain, the friendliness with which you explain, the kind of humble nature you carry, I must say that you are a total inspiration for the young neurosurgeons and for our committee. Thank you for your support. And Professor Oya, the way you put your drill on the earth and making it Antarctic and equator and all, that concept was truly awesome. The way you explained it, it was really fantastic. So with that, I think we can conclude. May I ask our chair, Dr. Liu, to make a final concluding remark, and then I will show you the poster for the next wireless session. Dr. Liu, can you say a final concluding remark?
Thank you very much, both Professor Azmi and Professor Oya. We find that now we have a totally different concept. We encourage the expert to teach basic things. And I find all these tips are valuable, and we would not be able to find in any textbooks. And hopefully one day our group will be able to assist both professors in writing up all these tricks and tips, and we can give to more neurosurgeons who would not get a chance to attend this webinar. With that, thank you both professors.
Thank you very much. And this is a conclusion of today's webinar. And may I present to you the, are you able to see my screen?
Yes.
Yes.
So this is the next webinar is going to be on the 13th of December. And the same time, our guest speaker will be Professor Abdul Samad Al-Kuhabi. And the endoscopic discussion is going to continue. Today we were endoscopic endonasal. Next session will be endoscopic, but it will be intraventricular. So Professor Alberto Faletti is a endoscopic surgeon, we all know. So next session, I think, but I need everybody's help to advertise more. Today we had a limited, less number of speakers. So maybe next time we can advertise more and let it be beneficial for the more and more young neurosurgeons, one thing. And at the end, let's say thanks to the Intas Pharmaceutical. They had given us the technical support today. So I think it went very well today. There was no hassle, very hassle-free webinar. So we must thank Intas Pharmaceutical for the support they have provided. This whole meeting will go and get recorded on YouTube, and we will edit it and get it on our YouTube channel. And once again, thank you very much, everybody, for participating. And for all the YNS members, please volunteer and send your abstract for the next ACNS virtual meet and the winter webinar, please. Thank you very much. Thanks a lot. At the end, we will take one final group photo. Can you all, may I request to switch on your videos, please? I think Professor Kato had messaged me that she was going. There was one case. So anyway, so keep a smile. I'm taking a photograph. Thank you. Thanks a lot. Okay, done. Thank you very much. Goodbye. Stay safe.
Thank you. Thank you very much.
Bye-bye.
Bye.
Thank you.
Okay, thank you, Sachin. Bye-bye.
Thank you, Liu. I think it was okay. I think we need more participants. Next time I'll advertise more better.
Yes.
So I've gotten, okay. Thank you, Sneha ma'am. Thank you very much. Your audio is off.
Yeah, and some of
Sorry, yeah,
our,
thank you.
yeah, some of our panelists, they have clicked the wrong link. Probably we when we send to them, we don't show them the participant link, so they won't make the mistake.
No. At the end, in order to have a more interactive session, I converted all the attendees into panelists, so they could directly ask their questions.
Yeah. I think it's
Actually,
better.
Sachin, I found a lot of them left before the actual Q&A.
Discussion. Yeah.
This is more information for everybody.
Yeah.
Let's just keep continuing what we can, and I hope next
Yes.
time we have more people.
I think we'll advertise more. So that this time I did not send that email of all that Indonesian and Indian and all neurosurgeon email you had. I had asked these Intas people to send it, but it could not work this time. Next time we'll work on it, and this mail will be sent to all the neurosurgeon list, whatever we have. So thank you.
Thank you, Sachin. Okay,
Sure.
bye-bye.
Thank you.
Yeah,
Bye.
Thank you, Dr. Liu. Yeah, bye-bye.
Prashant, are you there? Okay, no problem.
Sachin, I'm signing off. Thank you.
Sure, ma'am. Thank you very much, ma'am.